Chayan Singha from BSMMU.
Yes. Dr. Chayan Singha, start your case.
Good afternoon, Honorable Chairperson, respected panelists, and learned audience. Welcome to everybody on today's virtual session. I'm Dr. Chayan Singha from BSMU. Today, I'd like to present a case that is a paradox behind the scene in an adult of vasculopathy. My patient, a 50-year-old gentleman who is lean and thin, who was hypertensive for the last 3 years. He presented to us with ischemic type of chest pain and subsequently diagnosed as a case of non-ST elevated MI. Initially, he presented with palpitation in a tertiary hospital where he was diagnosed as a case of supraventricular tachycardia, and that was reverted back by adenosine. To search the risk factor, we had found that he had marked hypothyroidism with dyslipidemia. 1 month back, he was diagnosed as a case of tachycarditis for evaluation of claudication pain of his right upper limb and dizziness. And he was started treatment by MTX and steroid as per guidance of a rheumatologist. And he had a history of ischemic stroke 2 years back. On examination, he had tachycardia and high blood pressure, which was absent in the right side. This is the CT angiogram of the large vessel showing the complete occlusion of the right brachiocephalic trunk. This is the ECG in the left panel, SBT, after giving the adenosine shot, which showed the marked ST depression in the inferior lead and lead B4 to B6, and ST elevation in the AVR. Other investigation revealed inflammatory marker was completely normal. Troponin was raised. He had marked dyslipidemia and gross hypothyroidism with anti-TPO antibody was positive. Inflammatory marker IL-6 was done, it was negative. So our diagnosis, this is the case of non-ST elevated MI with history of SBT, hypothyroidism due to Hashimoto's thyroiditis, dyslipidemia, hypertension, and tachycarditis. As the patient presented to us with SBT and non-ST elevated MI, so we proceed for early CSG by a right femoral approach. Accordingly, in the left panel, we had found that there is a significant disease in the distal left main and osteoproximal part of LAD and osteal LCX. In the right panel, we had found that RC is non-dominant, and there's the breathing collateral, and there is nearly total occlusion from its proximal part. This is the still image showing the significant disease involving the distal left main, osteoproximal part, and osteal LCX. And this is we also done the peripheral CSG. We had found that complete and there is a significant disease in the origin of the left vertebral artery. So what should our plan regarding the coronary management of this patient apart from the other medical management? As the angle was around 90 degrees, so we had planned to dual stenting. We frequently, we and our team member frequently review the CD of the patient and geographic view, and ultimately we decided to dual stenting by tap technique. Accordingly, we engaged the 7 French review guide catheter, and through which 2 wiring was done in the LAD and LCX, and lesion was prepared by balloon dilatation. This is the balloon dilatation. And after which, first of all, we put a dilating stent 3.5 into 22 millimeter in the LM2 LCX, and it was deployed at 16 ATM. Then gel wire was removed from area in another recrossing wire was done, and 2.5 into 12 millimeter balloon, 9C balloon was taken, and start of the L6 was opened, and then approach to LED, and dilating stent 3 into 26 millimeter was negotiated into LED, and kissing balloon inflation was done. Here shows the kissing balloon inflation, and this is the final report was done by taking 4 into 8 millimeter NC balloon, and this is the final result showing the appreciating result, the good symmetry flow and myocardial blush. And we repeatedly follow up the patient. Apart from the antiplatelet, other medication, he also taking thyroxine, MTX, and steroid. If we review our case totally, that we had found that for diagnosis of tachycarditis, he has spent a long time, and 1 month later, he was diagnosed SBT and non-ST MI And we also evaluate thoroughly as a atherosclerotic evaluation and vasculitic evaluation. We found that hypothyroidism as due to Hashimoto's and dyslipidemia. CSG was done, showed the left minute bifurcated lesion. And our questions that whether should we could we prevent the this atherosclerotic disease if we early diagnose the hypothyroidism with dyslipidemia, and what may be the relation of Takashio and Hashimoto's thyroiditis followed by atherosclerotic disease. So ladies and gentlemen, from the presentation, my take home message is that absent and diminished pulse along with blood pressure difference, these are the striking features for prediction of the Takashio arteritis. Appropriate medical evaluation of patient is the cornerstone for early diagnosis and prevention of complication. Arrhythmia may be a presenting features of ACS. Appropriate planning, selection of the hardware, and good teamwork are key to success for interventional procedure. Vasculitis and atherosclerotic disease may run together, and treatment of the underlying disease with multidisciplinary team approach is very much important for a long-term prognosis of the patient. I am very much grateful to our team member, Dr. Arifur Rahman Shajol and Dr. Selim Mahmoud Bhai, my patient who has permitted me to present, and obviously BSCI to permit me to present this case here. And you know, we are passing a very tough time in this COVID crisis. And if we work together with our courage, with our dedication, with our passion, with our commitment, we can do anything for the benefit of the patient. Ultimately, we may gain our wonderful world again. Thank you very much. Thank you for your patient sharing.
Professor Khaled Mohsin.
Yeah, thank you. Thank you, Dr. Chayan. It's a really lion-hearted presentation. You have the name of lion by the end of your name. So it's a really lion-hearted presentation, actually. And it has addressed the many aspects, say interventional aspect, rheumatological aspects. So it is very important. And hopefully the patient remains symptom-free in the follow-up. And so do we have the question answer now, or we? Okay.
At the moment. At the moment. At the
So
moment.
are there any questions from the audience? If you have any questions, any question in the chat box, we can look in the chat box whether there is any question now.
Okay. Dr. Moin, I wanted to ask you a question. Yeah. Dr. Singh, what did you do with the right upper limb vascular disease? Anything?
Yeah, after consulting the rheumatologist, we put already MTX and steroids. Though the disease is inactive, and we had planned that we will continue steroid 1 milligram per kg body weight for 1 month. Then initially we taper the dose accordingly.
Now, Dr. Chayan.
So your plan is to manage the medically the upper limb disease.
Simultaneously, we also consult to vascular surgeon, peripheral vascular surgeon. He has told that after a couple of days later, you we may approach this total occluded brachycephalic or vertebral.
Okay. Sir, I have a question. I am Dr. Momin from NICVT.
Yes.
Can you hear me, sir?
Yes.
Dr. Chayan, thank you for your wonderful case. I have a question whether this coronary involvement is a part of Takayasu arteritis, vasculitis, or it is a different entity. Because only 10 to 15% patient may have arteritis of the coronary artery in Takayasu arteritis. So why not is a single entity or it is a different entity atherosclerotic disease?
Thank you, sir, for your nice question. We know that in Takayasu arteritis, there is 3 patterns of coronary involvement. Mostly osteal disease is more common, or there is tandem lesion, or there is aneurysmal dilatation. But here, the coronary osteal lesion is totally spared. And he had background history, the Hashimoto's thyroiditis, which may lead to secondary dyslipidemia, which leads to aggressive atherosclerosis. And we also search the inflammatory marker of active vasculitis, but interleukin-6, then TRP, ESR, absolutely normal. And he is on steroid and MTX. So possibly this lesion may be due to atherosclerosis, sir.
Dr. Chayan, may I have a question for you?
Sure, sir.
Actually, if a patient with Takayasu and a multivessel disease is referred to a surgeon for CABG. So what will be your message to the surgeon? Would you give any special message to the surgeon before these patients are subjected to CABG operation?
স্যার অবশ্যই আই উইল ডু সাবক্লাভিয়ান আর্টারি লিমা করে দিতে হবে বিকজ ইট ইনভলভস দ্য কমনলি লেফট সাবক্লাভিয়ান সো ইন টাকাশো arteritis the aggressive vasculitis occurs, so venous graft will be more preferable choice apart from the arterial graft.
Would you advise use of a lima in this group of patient or other than lima?
Other than lima should be preferred. Venous graft should be preferable, sir.
Why as a radial, as a free graft? Can you think about it?
Yeah,
Radial artery.
Takasho arteritis is a large vessel vasculitis, so radial graft could be an option, sir.
Thank you, Dr. Chayan, for your interesting case. And you have distal LM, LAD, and LCX, one lesion.
Right, sir. Medina on.
Why you have chosen this procedure, LM to LCX first, and then tap to the LAD? Why you have not chosen the other modalities of bifurcation like decay crash or nano crash or culotte?
Right, sir. Thank you, sir, for your nice question. Sir, the angle between the LAD and L6 is 90 degrees. So our target was to doing the tap technique, and we have done the LM to L6 first because the diameter of the L6 is more than LAD, and the angle between the LM to LD is acute angle. So the crossing of the ligament to LAD stent will be more easier for us. For that reason, we have put LM to L6 stent first, sir.
LM to L6 stent first. Another cause is their left circumflex is dominant vessel.
Right, sir. Right,
dominant
sir.
vessel.
Right, sir.
And in which strat you have entered from the LM to LAD?
Sir, we remove the gel wire and we approach through the distal stent start.
Usually distal.
Is usually, sir.
Distal stent. Thank you for your excellent presentation. I like to tell Dr. Professor Khalid Mohsin to ask to call the second speaker. Thank you.
Yes.
Thank you very much.
Yes.
sir.
Thanks, Dr. Chayan.